Good evening, all. My name is Alfy Olufade, and I will be hosting this week National Fellow Online Lecture Series. As a reminder, this is sponsored by AMSSM Fellow Online Education Subcommittee, the AMSSM Education Committee, as well as the Fellowship Committee. It is with great pleasure that I have a colleague and a friend of mine, Dr. Yaw Boachie-Adjei, that will be speaking of phalangeal and finger injuries today. Just as a quick reminder, we have an upcoming lecture on mental health in sports by Dr. Proximal, as well as Alexis Koslik, who will be moderating that session. That will be on Wednesday, 10/25/2025 at 8:30 p.m. Eastern Time as usual. As a reminder, this lecture serves as an adjunct to your individual program educational programming, provides fellows with direct access to educational experts with experienced AMSSM members and at times guest speakers like we have today. The goal is also to assist in CAQ exam preparations. Just a few housekeeping rules before we get started. Please remember to mute your device and turn the video off. Please submit questions you have through the chat function, preferably with your name and the program that you are located. Myself, as the moderator, will ask the questions during the last 15 minutes or so of the session during the Q&A part of it. And that's kind of it. So before I get started, I'd like to read a quick bio intro on Dr. Boachie-Adjei before he gives his presentation. After graduating from Brown University with an honor degree in human biology, Dr. Boachie-Adjei received his medical degree at Tufts University School of Medicine and completed an orthopedic surgery residency program at University of Virginia. Yaw developed an interest in all conditions of upper extremity and made a decision to pursue a dual fellowship training. He did 2 years of subspecialty training in endomicrovascular surgery and then in shoulder and elbow surgery. After fellowship, he was at Southeast Permanente Medical Group in Atlanta for about 9 years. He's also involved with a foundation of orthopedics and complex spine focus, which is a volunteer group that provides orthopedic care in the underserved communities in Ghana, West Africa. In his spare time, Dr. Boachie enjoys spending time with family, running, cycling, and hanging out on the beach. Once again, thank you, Dr. Boachie, for joining us today. I'll stop sharing. That way you could go on next.
Thank you. Dr. Olufade, I appreciate the info, the introduction. As Dr. Olufade said, my name is Yaw Boachie-Adjei. I'm a shoulder, elbow, and hand specialist at Duke University. I've been here for about 3 years. While I was in Atlanta, I had the opportunity of both collaborating and becoming a friend and colleague with Dr. Olufade. So it was my pleasure to do this talk, and I immediately said yes when he offered me the opportunity. So I was also telling him I just finished a half-hour talk on shoulder and elbow revision surgery. So I've had to kind of switch my mind here and get back into the fingers and athletic injuries. So today we're going to talk a little bit about phalangeal fractures and finger injuries, topics that are both very germane to you all's areas of interest in training as sports medicine fellows. So the goal is to go for about 30 to 45 minutes. We're going to go through quite a bit, and I'm always okay taking questions, or we can save those for the end. To start, I want to just give a shout out to one of my partners here at Duke University, Tyler Pigeon, who helped me with some of the surgical slides and some of the organization of this talk. So just give him a quick shout out. Goals for tonight is to go through general history and physical exam for somebody presenting with what we think might be a finger or a phalangeal injury. We'll talk quite a bit about the indications for both operative as well as non-operative care. We'll discuss some splinting as well as casting, both for somebody who is not going to return to play and somebody who is going to return to play. And then again, we'll do a little overview on return to play for different types of injuries. We'll intersperse a little bit of literature in there as well. And then as a surgeon, I'd be remiss if I didn't show you some very pretty intra-op and post-operative X-ray pictures from some of my patients. So if you would just humor me as I show you some surgical pictures. So before we get started, I think it's really important to have a common sense of just the nomenclature of the finger. So as we all know, the finger comprises of 3 parts. There's the distal phalanx, the middle phalanx, and the proximal phalanx. And in each phalanx, there are different anatomical landmarks or anatomical portions of each of the phalanges. In the distal phalanx, you've got the tuft, you've got the shaft, and you've got the base. And then in both the middle and proximal phalanges, you've got the head, the shaft, and the base. There are joints in between both the proximal, middle, and distal phalanges, the PIP joint and the DIP joint. And it's really important, again, to know the portions and know how to describe them, because as we talk about the different fractures, I'm not only going to break them down based on each of these locations, but you'll see the different types of injuries are treated very, very differently based on where they're located, whether it's proximal, middle, or distal, the base, head, or shaft. So as medical professionals, we all know the most important thing that we can do is talk to the patient. You've got to get a very good history. You get the history before you get the physical. And germane to what we do, it's really important to know what their age is, obviously the activity level, know if it's a dominant or non-dominant hand injury. As sports medicine, or as folks who take care of athletes, you got to know what their sport is, as that will really guide how you treat these folks as far as more aggressive versus less aggressive. And then for those who are not athletes, knowing what their occupation is. We would treat an 80-year-old, great-grandmother very differently than a 17-year-old baseball player with the very same injury. Getting a sense as to their past medical history is very, very important. Knowing any, obvious comorbidities that may compromise or make care more difficult, whether it's operative or non-operative. So you got to get a good history. Mechanism of injury is very, very important, because oftentimes the mechanism of injury can give us some clues as to the nature of the injury. A lot of times I'll have patients that come into my clinic and they say, I was walking my dog and I had the leash wrapped around my finger. The dog ran that way, my finger went the other way, and I know immediately it's either an IP joint dislocation or a spiral type fracture of their phalanges. Somebody else might come in and say, I was playing football and the helmet of one player hit the helmet of the other, and my finger was right in between. I know pretty quickly it's some type of crush injury, likely the distal phalanx. So getting a good sense as to the mechanism of injury and as much detail as possible, that can give you some great clues as to what's going on. Knowing their history of any previous injuries or treatment to that same hand and specifically that same finger. If somebody's had multiple finger joint dislocations and they come in and say, my finger was jammed by a basketball, is it broken? If you look at their other fingers, then they're very gnarled and swollen at all their IP joints. You might just say this might just be a joint sprain, as opposed to immediately worrying about some kind of fracture. So knowing if they've had previous injuries in that same finger or hand, knowing if they've had previous surgery, splinting of that same finger or hand is also very important. And then for open injuries, for lacerations, it's obviously good to know what their tetanus and their other vaccination status is, just so that we can make some decisions at time 0 if they present to our clinic with some kind of laceration. Next part, as we all know, is physical exam. Physical exam is where we can really get a lot of great clues. Move that over. Sorry. So it's important to take a look at the skin integrity. Again, I mentioned before, look at any lacerations. That can be a telltale sign as to bony injuries, also tendon injuries or ligamentous injuries. Look at the nail bed integrity. Subungual hematomas can give you a lot of clues as to what might be going on, and I'm going to touch upon that a little bit later. Neurological evaluation is very important. You want to check light touch. Getting 2-point discrimination is not always super easy, but get a sense as to whether they've got a lot of numbness or tingling in their finger, if that's the only finger that's affected neurologically, because that can also give you a sense as to any digital nerve injuries, or even any injuries that are more proximal, like something in the carpal tunnel, especially if they've had some kind of crush injury to their hand that might be causing some carpal tunnel pathology. Capillary refill pulse, obviously very important. Checking their tendon function, flexor and extensor tendons, super important. I will touch upon this a little bit later, but flexor and extensor tendon injuries can be associated with different types of fractures in the phalanges. And again, getting a good history and physical exam, checking their tendons to see whether they can move their fingers can give you some clues as to what might be going on. Ligamentous injuries, we're typically worried mostly about the collateral ligaments in their IP joints. So checking varus and valgus laxity can give us some clues, whether it's in the fingers or even in the thumb, especially things like UCL or ulnar collateral ligament injuries. So looking to see if the finger is kind of drifting off to the side or if it's in line with the other digits, very, very important. And then you can't forget to look at the rest of the hand and then check the forearm. Again, if somebody has had a really bad crush injury, or if their hand has been impacted between two hard surfaces, like somebody getting some weights dropped on their hand, getting their hand caught between two football helmets, you want to definitely check and make sure that their compartments are nice and soft, not only in their hand, but also up in the forearm. I mentioned earlier, looking at the nail bed status, very, very important. So we all know what subungual hematomas are. It's essentially bleeding of the germinal matrix, bleeding of the nail matrix underneath the nail plate. And that hematoma, suggests the presence of a nail bed injury. If that hematoma is more than 50% of the area of the nail plate, you've got to be concerned about not only a nail bed injury, but that the injury that they had caused enough force to cause some type of distal phalanx fracture. So get a good look at the nail bed, see if there's a large subungual hematoma, see if it's evolving, see if it's been there for a while. Got to ask all those questions. And if somebody comes acutely with a subungual hematoma to your clinic, or if you're doing some sideline coverage and somebody has a large evolving subungual hematoma, decompressing this can actually be very, very helpful as far as decreasing damage to the nail bed and also decreasing the severe pain that a large subungual hematoma can cause. Looking at the digital rotation is really, really important. Typically, all of the fingers, if we turn our hands palm up and make a fist, all of the fingers should line up with the scaphoid tubercle on the volar surface of the palm. So they should essentially line up at the scaphoid tubercle, which is kind of in this area, or dorsally on the scapholunate interval. But again, they should all be somewhat parallel in a array that essentially converges right around the scaphoid. That's normal. If somebody comes into your clinic and you ask them to make a fist, and their hand looks something like that, the concern is that they have either a metacarpal fracture or some kind of phalanx fracture. That would give you some type of rotatory deformity. So checking the status of rotation of their fingers after an injury is very, very important. Now, if somebody comes in and they're 90 years old and they've got bad rheumatoid arthritis and they've got ulnar drift of their fingers, this is obviously out of the window. But if it's somebody who's young, healthy, normal, or an athlete, and they've got rotatory deformities of their fingers, you're immediately worried about some type of phalanx fracture. So next step would be get some imaging. Whether you have an obvious external rotatory deformity, angular deformity, if somebody's got a bad bruise and difficulty moving their finger, or an obvious injury, X-rays is the most appropriate, quick and dirty modality for imaging. It'll show you different types of fractures. It'll also give you a sense as to whether the bone is normal. It'll give you a sense as to whether they've got decent bone quality, if they've got bad osteoporosis. It might also give you a sense as to whether they have bone lesions. I've had people come into my clinic and they've got a phalanx fracture. I get an X-ray and I see a large enchondroma within that phalanx. That really changes treatment, because typically if somebody's got an enchondroma, and even if it's a nice transverse, not severely displaced fracture, these oftentimes don't heal. And we typically have to, curette out the enchondroma and then pin or put screws in that fracture because they have difficulty healing. So look for bone lesions. X-rays will also give you a sense as to the fracture pattern, transverse, oblique, comminuted, and also fracture alignment. Because as I'll discuss later, we use all of those different numbers, alignment, degrees of angulation, degrees of rotation, to make decisions on splinting, casting, or potentially operative treatment. Advanced imaging such as CT scans and MRIs can be helpful. So we'll start with CT scans. If somebody's got a really bad intra-articular injury that you see on an X-ray, getting a CT scan can be very helpful because it can show you the number of fracture fragments. It can show you some type of die punch type injury. It gives you a little bit more information as to the nature of the fracture. And then if you're concerned about some type of ligamentous or tendinous injury, an MRI can be super helpful. If somebody comes in and they cannot flex one of their fingers that's been crushed or has had some type of injury, obviously flexor tendons can be a concern. An MRI can show us the proximal migration of a flexor tendon. So always start with x-rays. If there's a high suspicion for some type of deeper or more severe injury, advanced imaging can be very helpful. So we'll start with distal phalanx fractures. We'll just work away from distal to proximal. So we'll start with distal phalanx. So the distal phalanx fractures are the most common fracture in the hand, with the small finger being the most common. That is a border digit, and somehow that one seems to get caught out. About 40% of distal phalanx fractures. These fractures can be either at the tuft, the shaft, or they can be at the base, intra-articular. So tuft fractures are typically crush type injuries. Because they've got a nice soft tissue envelope, they can often be associated with nail bed injuries. But at the same time, because they've got a good soft tissue envelope, they rarely require surgery. Focus is typically on looking at the surrounding tissues, the nail bed, the pulp, to make sure that there are no open injuries, that there's no severe nail bed injuries, or that there's no displacement of the proximal nail plate through the epidicule fold. But these are typically lowest on the acuity level, but there are times where you can be caught out with these distal phalanx tuft or shaft fractures, and you've got to have a high suspicion for some of these. For these shaft fractures, again, just like the tufts, they're stabilized by the surrounding soft tissue and rarely require surgery. Importantly, you can have an open fracture through the nail bed. It's called a Seymour fracture, and I've got a slide on that. Where that distal phalanx shaft can actually protrude through the nail bed and the nail plate. And that can be an emergency because these can be very serious injuries that require both antibiotics, irrigation, and potentially a nail bed repair. Sometimes they even require fixation, and missing these injuries or neglecting them can lead to osteomyelitis and some other pretty bad issues. So we'll go a little bit more into depth about that. And then these intra-articular base fractures of the distal phalanx. So we've all heard of mallet fingers and jersey fingers. I'll talk a little bit about those. So even though the DIP joint tolerates insults better than a PIP joint and doesn't often require surgery, you've got to be very suspicious about tendon injuries. So dorsal injuries can be the extensor tendon. Molar injuries can be the flexor tendon. We've all heard about mallet fingers and jersey fingers. Again, we'll talk about that, but these are things that cannot be missed. So we'll just start with non-op treatment of a distal phalanx. Let's say somebody comes in, they've got a crush injury and a minimally displaced tuft fracture. Typically, you can put them in some type of splint to just protect the soft tissue, give it all a chance to rest. That's typically for anywhere from 3 to 4 weeks. Importantly, you want to allow the IP joint, specifically the PIP joint, to move because you don't want to lock up the whole finger if you're just treating a non-operative distal phalanx fracture. Now, if it's a grossly displaced fracture or an unstable fracture, that would be operative, and we'll talk about some instances of that. In the distal phalanx fracture, radiographic evidence of healing can be pretty slow. It can take months before you see really good healing. So I've got people that I've treated in the past with distal phalanx shaft fractures or tuft fractures, and we deem that it's non-operative, and we get an x-ray 6 weeks later, there's not a bunch of healing. You get an x-ray 3 months later, a little healing. You get an x-ray 4 months later, and you see a little bit of healing, but they're feeling fine. A lot of these fractures can go on to an asymptomatic fibrous union, where you do see a little bit of bone, but there still might be a fracture line. But if the finger is stable and it supports the nail plate, that's okay. I always counsel these people that with distal phalanx fractures, you can have cold intolerance, altered sensibility, and nail plate deformity. That cold intolerance or altered sensibility can last for up to a year or more. And the nail plate deformity just depends on the nature of the fracture, but it's important to counsel these patients with distal phalanx fracture that you might have some issues with that finger, even though we didn't do surgery and you healed up just fine. Again, the majority of these are non-op and they go on to good healing. So when do we need to be concerned about these distal phalanx fractures? I mentioned a couple of things before. So the first thing is something called a mallet fracture. This is a distal phalanx base fracture. It's an injury on the dorsal side of the finger, and it involves the extensor mechanism. Now notice I didn't say the extensor tendon. By mechanism, I mean it can be either a soft tissue injury, which is an extensor tendon rupture, or it can be a bony injury, which is an avulsion fracture. Typically, these are caused by a forcible distal interphalangeal joint flexion injury, such as catching a football or a baseball, and you don't quite catch it the right way, and it forcibly flexes your finger down. That quick amount of force and downward pressure can essentially cause the tendon to rupture right off of the distal phalanx. Now, it typically does not proximally migrate. It typically stays close to the DIP joint, but folks will come in with a bent down finger, very characteristic appearance of a mallet injury. You can also have a mallet fracture, which is an avulsion fracture, where that same forced DIP flexion can cause a small piece of the dorsum of the base of the distal phalanx to pull off. And that sometimes does translate dorsally and proximally, and that can also be a pretty bad actor. So these mallet injuries, if somebody comes in, I always get an x-ray to make sure that there is no bony fragment, because some of these will need an operative procedure. Again, get these radiographs to see if there's a bony injury. The majority of these can be treated non-operatively with DIP extension splinting. I'll typically put them in something like a stack splint. I showed one of those earlier, some type of DIP extension splint, or even a custom-made thermoplastic and Velcro strap. These work really well for more active folks. Typically, I do 6 weeks full-time splinting, and I tell them that you want to keep your finger as straight as possible when you're taking a bath or a shower. You want to lay your finger across your chest before you take the splint off, because every time you flex the finger down, you're pulling those two ends of the tendon further apart and compromising your overall recovery. And then we do 6 weeks of nighttime splinting. Rarely do these folks need formal occupational hand therapy. I give them a simple set of exercises. So extension, stretching, splinting, they typically do well. I do tell them that at the end of all this treatment, 12 weeks, you might get up to a 20-degree extensor tendon lag. And that's only because as that extensor tendon does heal back together, there is a little bit of fibrous tissue, and it's not quite as stout as your normal, good, healthy extensor mechanism. So there'll be a little bit of a lag, and I tell them, look, if we did surgery, you'd have potentially a pin, and you might still have a lag. Now, when do we do surgery on these? If there is a large enough fragment, so greater than 50% of the joint space, as you can see here, there's a pretty good sized fragment that involves about 50% of that DIP joint space here. Or if there's volar subluxation. So as you can see, this distal phalanx is volarly subluxated. So it's not in line with the proximal or middle phalanges. It's sitting down a little bit. So those are instances where just extension splinting will likely not work, because it's hard to get a union between these two fragments. So what we'll often do is something called dorsal block pinning, where we use a number of K-wires to essentially affix that dorsal fragment. And we typically leave those in for about 6 weeks in order for that bone to heal. These folks typically do really well. And I'd say they probably do a little bit better than the folks who are treated completely non-operatively for the soft tissue mallets, because you really get that bony opposition, and that finger is basically straight for about 6 weeks. The other type of injury that can happen in the distal phalanx is the jersey finger. Again, for folks who are playing sports and they come into your office, they might say, hey, doc, I was diving for a tackle and I grabbed the jersey and I felt a little pop, and now I can't bend my finger. Telltale story for some kind of volar injury, typically a flexor tendon, called the jersey finger. So these typically involve the flexor tendon. It's essentially, forcible extension of the finger as you're trying to flex that finger. The important thing with these is if somebody comes in and they can't flex their finger and they've got no laceration, you're thinking flexor tendon all the way, get an x-ray. You don't always see anything on an x-ray, but sometimes you might see an avulsion fragment, which indicates the portion of the bone that the flexor tendon, that FDP tendon, has pulled off of the volar portion of that distal phalanx. MRI can be helpful as well, because you want to determine the level of migration. So the important thing is you've got to know the classification of a jersey finger, and that can help you to help you determine whether to get an MRI or not. So there's something called the Leddy-Parker classification, where you've got 3 different types of these FDP avulsions. So the very worst type is a type 1. So with this, you get FDP avulsion with retraction all the way down into the palm. So the FDP pulls off of the distal phalanx, retracts through the entire pulley system, and it ends up way back here in the palm. These folks will come into the clinic, say they tried to grab something or they had a forcible eccentric extension of their finger, and now they can't bend that finger. Immediately worry about a jersey finger. Because it's a purely tendinous injury, you're not going to see that same bony fragment. Okay? So an MRI may show the tendon retracted back in the palm. That is a surgical issue. So you'd send them to somebody like myself. A Leddy type 2 is where you have FDP avulsion, but that stump actually remains within the sheath. Okay? A lot of times with either a type 1 or a type 2, you might still see a very small, tiny avulsion fragment. The other thing that you might see, or that you might see on your physical exam, is they can't bend their finger, and as you palpate the volar portion of their finger, you'll find a spot that's either has some fullness or a spot of point tenderness. That's usually where the FDP tendon has retracted to. That'll give you a good sense as to the level of the injury, but I'd still get an MRI. And then the last type of jersey finger is a Leddy type 3. That's where you have an FDP avulsion with a bony fragment. And believe it or not, even though that sounds terrible because you got this bone, it's actually the best type because that bony fragment prevents the FDP from retracting proximally beyond that distal pulley. So it usually stays right here, very closely approximated to that DIP. Again, these are almost always surgical. I'd say they're always surgical. You don't want to leave an FDP injury. So evaluate them, good physical exam, get your proper imaging, usually an MRI, and you want to send them on to a specialist. All right, I spoke earlier about the types of distal phalanx fractures that we cannot miss. So jersey and mallet finger, we cannot miss those. Another type is something called a Seymour fracture. So this deserves special recognition because missing this type of injury can be pretty devastating. This is something that's unique to children, though I have seen a Seymour variant in adults. Essentially, folks get a fracture right through the proximal physis in that distal phalanx. So they essentially get a forced flexion, or it's a crush injury that causes the distal portion of the distal phalanx to intussuscept through the nail bed and even through the nail plate sometimes. So what you'll see is the proximal portion of the nail plate has been dorsally translated, and it's basically ripped through the epinicial fold. Again, something that we can't miss. Anytime somebody has an injury like this, I always get an X-ray because this essentially is an open fracture. If not properly treated with proper reduction and fixation, as well as irrigation and debridement, this can lead to septic arthritis and osteomyelitis. So very, very important. You've got to not only fix the nail, not only fix the fracture, but also fix the nail bed. So can't miss the Seymour fracture. That's a bad one. Again, this can happen in adults if you get the right force and you get a fracture at the base of the distal phalanx, but most commonly in children because of the weak point in that distal phalanx physis. So quick case, again, I'm a surgeon, I got to talk about some cases. So this is a patient who had injury while playing football. He said that he was running, he ran to tackle somebody, grabbed the person's jersey, and then he said his hand was also forcibly hit. So on the AP, doesn't look like a whole lot's going on. The joint space looks reasonable. There's no rotatory deformity. There's no angular deformity, no obvious fracture, but it's always important to get 3 views of the fingers. So AP, oblique, and laterals, because the lateral does show a couple of telltale signs. Number 1, there is what appears to be a dorsal fracture. So maybe a bony mallet, okay? That's not displaced, but we do see a dorsal fracture. And then on this lateral here, we can also see this little fleck of bone on the distal portion at the base of the middle phalanx. So again, we'd be concerned about a jersey finger, okay? And this is something that was treated operatively after the MRI confirmed proximal migration of that FDP tendon. He was found to indeed have an FDP avulsion. So that was fixed with extension pinning of the DIP joint, as well as primary fixation with bony anchors of that FDP tendon. Patient did really well, and he got his function back. All right, so now moving proximally, I'm going to talk about both proximal and middle phalanx fractures kind of in the same group here because they're very similar in both presentation and treatment. And again, they're quite different from a distal phalanx fracture. So these can be both extra-articular or intra-articular. Extra-articulars are obviously much better than an intra-articular fracture. These can obviously, these can typically be treated with buddy taping, especially if you've got less than 10 to 15 degrees of angulation, 2 millimeters of translation, and no rotatory deformities. You again want to get good x-rays to get a good characterization of these fractures. If there is a little bit of angulation, they don't automatically need surgery. Sometimes you can do a very gentle reduction to try to get the bone lined up. However, if it's very displaced or unstable, you treat them surgically, especially if they're irreducible, if they're comminuted, if they got associated tendon injuries, or if somebody's just really, really active and you want to allow for early return to play. But these can often be treated, whether they're oblique fractures, transverse fractures, if they're not extremely translated, angulated, or rotated, can often be treated with buddy tapes. And I'll talk about that in a couple slides here. So similar to the distal phalanx fractures, you've got base, shaft, and neck fractures. Fractures at the base oftentimes lead to apex volar angulation, and that's because of the pull of the flexor tendon. Typically, if there's more than about 25 degrees of angulation, you do want to treat these surgically. If you leave that, you can definitely cause loss of motion in the flexion extension plane. Shaft fractures tend to be the most forgiving, but again, because of that flexor tendon pull, you can get apex volar angulation because of the flexor tendons as well as the insertion of the intrinsics. And then neck fractures are most common in children, easy to miss. You've got to get a perfect lateral. I'll show you some pictures of some neck fractures. Got to get a perfect lateral so you could see right down the physis. Again, if you have a physeal injury, there's not a whole lot of remodeling potential. So with these neck fractures, I'll show some examples. They typically do require reduction in closed reduction percutaneous pinning. Talked a little bit about non-operative treatment. So for a lot of these middle and proximal phalanx fractures, especially if they're extra-articular, buddy taping is a great option. And buddy taping is just kind of a general term. You can obviously use tape, but I tend to use buddy straps. It's usually a Velcro strap that really allows you to stabilize these minor injuries. And the whole point is to tape or strap the injured digit to a healthy one. And that healthy one does a couple of things. It acts as a natural splint and protection, but it also helps to initiate early active motion. These folks come in with very swollen, stiff fingers that they don't want to move. Buddy taping protects that finger and gives them a good sense of security, but it also allows them to move their finger very gently. It's very difficult to move that injured finger on its own, but when strapped to an adjacent finger, you do get a little bit of motion there. Now, obviously, if somebody's got an open wound, severe deformity, intense pain that has you really concerned about a ligamentous injury or some kind of neurovascular injury, we don't just buddy tape them, but it does work for a lot of these minor finger injuries or middle and proximal phalanx fractures. It's important to pad between the fingers. It can get pretty moist in there, so I'll usually put a little piece of gauze in there or some web roll, and then I'll show them how to tape it. And for athletes, it allows patients with stable fractures or even bad sprains to return to sport a whole lot faster. A lot of PIP and DIP joint sprains where they're stiff and swollen, but don't need a surgery. Buddy taping is a great way to get folks back, especially if it's a non-dominant hand or if they're if they're a position player. Oftentimes, buddy taping is a great way to protect them and give them a good sense of security so they can get back to sport faster. All right, so this is a slide that I would say y'all should screenshot and just take with you. This is basically a return to play timeline for buddy tape finger fractures. So for a stable, non-displaced fracture of a phalanx, this is a really good guideline that I took a lot of different literature, and I actually fired it all into Gemini, and I got this really beautiful table. The power of AI. So first 3 days, initial assessment, immobilization. So you want to rest, you want to get x-rays, you want to diagnose what's going on. If you've got a stable or a non-displaced fracture or a bad sprain, buddy taping is totally reasonable. You do that immediately. You want to give the finger a couple days to rest. I wouldn't get them back into practice or games right away. Give the finger a couple days of anti-inflammatories, maybe some ice to kind of get better. And ideally within the first week, the athlete can be cleared to get back into some kind of participation, at least getting back to practice. Now it does depend whether it's contact versus non-contact sports. Again, very nuanced, especially if it's a high impact ball sport like football or basketball. If it's something that that does not require a lot of dexterity, like a lineman, a kicker, a runner, or the offhand of a paddle sport player, much quicker return. But if it's a dominant hand and a thrower, a quarterback, a basketball player, you might slow them down just a little bit. So again, potential return to practice within the first week or so. Between 2 and 4 weeks, even if the athlete is starting to feel better, I would actually continue with buddy taping, because what you'll find is, obviously with fractures, they can continue to have pain. The fracture is not healed yet. But even with a bad sprain, that joint is going to be more susceptible to repetitive injury within the first 6 to 8 weeks. So I typically would just continue buddy taping, and I just tell them for about the first 6 to 8 weeks total. After that time, they can kind of slowly wean off the tape after they've kind of gotten some of their motion back, if it's a sprain. If it's a fracture and the x-ray does confirm some decent healing with callus formation, you can take the tape off for daily activities, but I would continue with the taping for practice and for games as well. Hand therapy is super helpful to rebuild grip strength and dexterity. And this is important for preventing long-term stiffness. And then as far as clearance to play without any taping at all, for me, it's at least 6 weeks. Again, you can re-injure a sprain within the first 2 months. And certainly if you've got a fracture within the first 2, maybe even 3 months, I'll still protect folks and say, put some tape on before you get back to kind of full play without anything. All right, again, I'm a surgeon, so I gotta show you some cases. So this is a oblique fracture of the proximal phalanx. As y'all can tell, there is a little bit of shortening, a little bit of rotatory deformity, which you can see on this x-ray here. And then there's a little bit of that apex volar angulation from the pull of the extensor mechanism. So this is something that would be surgical. Couldn't buddy tape this because of that rotatory and extension deformity. So very easily treated with a couple of small screws, 1.8 millimeter screws, to get good stability. So this is somebody who, if they were an athlete that came to my clinic, I'd get them fixed, and I'd probably let them get back into practice within the first 2 weeks with some kind of either a thermoplastic splint that covers the wrist and the affected finger as well as the adjacent finger, or if it is a non-skill, and I hate to say that, but like a lineman, potentially some kind of club cast. Great healing on this fracture here. This is a transverse fracture, again, that typical apex volar deformity. Sensor mechanism pulls on that finger. Another operative fracture. This is not going to hold if just buddy taped or just reduced and splinted. So we do intramedullary screws. These are called AccuTrack screws. You can fire them right down the pipe. And again, good early rigid fixation. You can get them back to play with protection for a couple weeks. Excellent healing. All right, we spoke a little bit about proximal and middle phalanx neck fractures. Again, these are often seen in children at the physes, but they can happen really in anybody. So the only ones that we ever really treat non-operatively are these type 1s, where you get a minimally displaced fracture does not have that, again, characteristic kind of dorsal pull from the extensor mechanism. So something like this can be treated with the splint, with buddy taping, got to ensure perfect reduction on a lateral. Okay, super important for these type 1s. But anything that's beyond a type 1, whether it's a type 3 that's moderately displaced, or a type 2 with moderate displacement, or a type 3 that actually has the volar plate entrapped within the fracture and collateral ligament that actually has pulled it up, that has to be reduced, that has to be fixed. So these are ones that you do not want to miss. These typically require pinning across the DIP joint. So this is a proximal phalanx neck fracture. Instead of having a to P deformity, there's more of an ulnar deformity. This is a very unstable fracture. I wouldn't buddy tape this. It's something that I would treat surgically with something like pins. Okay. Again, the only ones of these that we treat non-operatively is if they are completely non-displaced. Patient healed well. All right, moving a little bit more proximally. Now we're going to talk specifically about the middle phalanx shaft. Again, if these are less than about 15 millimeters angulated, less than 2 millimeters displaced, not shortened, you can treat these non-operatively with buddy tapes and buddy straps. If they are angulated and you can't get them reduced, it is operative. But sometimes these can be reduced with a little bit of a digital block, gentle manipulation. You can reduce these into a decent position. If they're displaced, if they're unstable fracture patterns, such as a oblique fracture, or if there's any combination, typically we're doing open reduction internal fixation, closed reduction per pinning, or intramedullary fixation. All right, and then intra-articular fractures. These are pretty much all bad. The most common type you'll see are these condylar fractures. So the condyle is essentially the head of the phalanx. You can have a unicondylar fracture that can be either stable or unstable. Because of the nature of the collateral ligaments that attach at the sides here, these are majority of times unstable if there's a fracture in the sagittal plane like this. Sometimes the coronal plane fractures are more stable because you don't have the same collateral ligaments pulling on them, and the extensor and flexor mechanism does not attach on the dorsal condyle or on the volar condyle. So these tend to be more stable than these sagittal plane fractures. These are pretty bad actors. The thing that you worry about as well, if you have any displacement, is post-traumatic arthritis within that IP joint. So these are usually something that you're not going to buddy tape and see back in a couple of weeks. Typically, these will be bumped up to the next level of acuity for perk pinning or open reduction internal fixation. Central slip avulsion, it's really hard to get that. Usually you'll see that, if at all, with the dorsal coronal fracture. But I don't know that I've ever seen this where the central slip just pulls off of here, because in actuality, the central slip runs the whole length of the finger and it inserts way distally. So it's hard to get any kind of mallet type injury if you've got a dorsal coronal fracture. Again, we talked about collateral ligament avulsion. That's usually with these sagittal fractures. And again, if you've got a collateral ligament or a depressed fracture like that, that's usually something that we'll treat operatively. We're going to talk about these pilon fractures. These are probably the worst types of fractures that you can have. The issue with these are you get shortening, you get comminution, and you end up getting a joint that's basically blown wide apart. I'll show you an example of that. It's usually from a longitudinal, just kind of axial injury that just crushes the base, and it's usually the middle phalanx. Again, for these base, so now we're talking about base fractures. We talked about shafts, we talked about necks, now we're talking about proximal middle phalanx base fractures. So these have a very high chance of getting that apex volar deformity because you've got the entire central slip over the dorsum of the finger, and these almost always go into extension. Now, you can accept a surprisingly large amount of apex volar deformity, so up to 25 degrees. Because a lot of times these people will get their flexion back even with 20 or so degrees of apex volar deformity. Typically try to reduce them, but again, there's a surprising amount of apex volar deformity that can happen. We usually see these in the small and ring fingers, so those ulnar border digits. If you've got a fracture that's showing more than 25 degrees of deformity, typically we're going to fix these, with perk pinning being the most common thing. And we usually go anterograde. I'll show an example of that. We rarely use plates, but again, perk pinning, and I love using these intramedullary screws, and I'll show you how that works. All right, so this is a proximal phalanx base fracture with probably 60 degrees of apex volar angulation. So that is not one that I would try to reduce because there's not a whole lot of bone stock here proximally. There's not much for that distal portion to really rest on. So that is one that I would not try to treat with buddy tapes or with the ulnar gutter splint. That's one that I would certainly refer for higher acuity treatment and fixation. You can percutaneously pin that. Typically the pins will stay in for about 4 weeks. And you can cut these pins short. I cut these pins short at the skin. If they're an athlete, I'll put them into an ulnar gutter cast and I'll let them go play. These pins are relatively stable. So this is final healing. Again, got good reduction of the bone, excellent healing. This is another volar base fracture. A little bit harder to see if you just look at this AP. Something doesn't look right centrally. And also you see a little bit of more angulation on this ulnar side. The oblique shows that you do have a little bit of an issue. And then when you go to your full lateral, there's definitely a problem in this area here. So that is one where it was a base fracture with a little bit of a condylar split treated with these percutaneous pins. And these are really nice, especially for athletes, because it's essentially 2 little stab holes right at the knuckle. You sneak these pins in, you put a little bit of skin glue on them. And I've gotten athletes back into practice in a week because this is rigid fixation because these are differentially threaded screws. So you'll get a little bit of compression across the fracture site and it's rigid. I'll get folks back to practice in about a week with a thermoplastic removable splint, and they do quite well. These also allow for early motion, so these are really, really nice. So that's this lady with the fracture here. Can't even tell which side was broken. Really nice fixation and great motion afterwards. And then last one is an intra-articular middle phalanx fracture. So just the condyle here. Again, it's displaced. You're worried about the collateral ligament pulling on that fracture fragment, pulling it more proximally. So that is one that you would refer to a higher level of acuity, and that can be fixed with a cannulated screw. Pretty straightforward, pretty simple. We get them back to motion, back to therapy within a week, back to practice in a thermoplastic splint, again, at about a week or so. Beautiful healing. All right, I think we talked a little bit about, okay, this is another one. This is an intra-articular fracture. Again, a lot of surgical slides, but I got to do it. I'm a surgeon. So this is one where a CAT scan really, really helped. It showed the incongruity of the base of that middle phalanx. I would not accept this incongruity. As you can see, there's also a little bit of dorsal displacement and some combination, a little fleck there. That's one that we treated with a little tiny modular hand plate. Reduce that. You can still see a little bit of that avulsion fragment, but it healed up nice. Great motion. All right, I talked a little bit about that middle phalanx fracture dislocation. That's that pilon fracture. This is a really, really terrible fracture. These will not heal with non-operative treatment because you can get dorsal displacement of the middle phalanx, and then essentially the joint space is blown out. The best way to treat these are either with dorsal block pinning, where you flex the finger down, put a pin in the proximal phalanx, and that will allow things to heal. Or you could do this thing called the Suzuki frame, which is essentially an external fixator made by using K-wires and rubber bands. And that essentially pulls the fragment out to length, and it holds it there. And because of the rubber bands, this is actually a dynamic. Device where you'll be able to have the patient start some PT. And I have sent an athlete back with a Suzuki frame and a club cast. All right, I'd be remiss if I didn't talk quite a bit more about return to play. So again, the initial healing phase is always 1 to 6 weeks. Depending on the nature of the injury, whether it's a fracture versus a ligament injury, that'll really determine how long the finger is immobilized full time and when they can get back to practice. Athletes will always wear some type of splint or just buddy tape to the adjacent finger, okay? Most of these injuries, we can get them back into some kind of level of activity within the first couple of weeks. And then after 3 to 6 weeks, normal day-to-day use of the hand can resume. For pro athletes, it just depends on the level of and the nature of the fracture. I don't love covering sports because I don't like coaches telling me how to treat my patients. That's just me. So this 6 to 12 weeks, a lot of times the coach will look at you like you're crazy. But with the right type of casting and splinting, you can get it back before then. But usually for light contact sports, and this is for non-athletes, about 6 to 12 weeks. Protected play, again, in some cases, athletes can get back to that level of play sooner, within 1 to 2 weeks. All right, use of a playing cast. I've mentioned this many, many times. So these club casts can be used. If you've got a stable non-displaced fracture that you buddy taped or put a splint on, but somebody plays football, you can just put a big old club cast around it. There are guidelines as far as how these club casts have to be applied and padded. All right, you can't just send them down to the tech and throw a club cast on them. Each different league, and I know certainly in the college and the professional, they have very different specifications for the form of the club cast. You can also use these for post-surgical fractures and also for ligament or tendon injuries. And there are these cast protectors that you can put over the cast. All right, typical hand injury return timeline in a cast. So in a cast, essentially, I let them go back quite a bit sooner. Right here, return to play, it can be immediately, even if they've got a fracture, because that cast really protects everything. As long as you've got the proper splinting or operative fixation, whether it's pins, screws, wires, that cast does a great job of just protecting everything. So for certain people, that cast goes on, they can get back into either modified practice or competition within the first couple of weeks. And I use the cast for about 6 weeks before I allow them to play some without it. They'll also do formal rehab. And then usually after 6 weeks, it's unrestricted return to play without a cast. All right, so just talking about return to play op versus non-op. This is a study out of Iowa in 2019, where they looked at the time lost in male student athletes for those who had non-operative treatment of fractures versus operative treatment of fractures. So the long story short on this is there were a greater number of fractures treated non-operatively, and there was a faster return to play for non-operative fractures, which kind of makes sense because usually if a fracture does not need surgery, I would assume there's lower acuity, you get them back sooner. But nonetheless, even for operative fractures, for metacarpal fractures, they were getting back after about 3 weeks. And then for phalangeal fractures, they're getting back after about 4 days. So if somebody does have an operative fracture, again, with the proper use of splinting, bracing, plus minus casting, you can get them back pretty quickly, even with surgery. All right, here are a couple references. Thank you guys for your time.
Thank you very much, Dr. Boachie. Andy, do you mind maybe putting my camera back on? We have a few questions. I know we have a few minutes. I'll try to kind of ask Dr. Boachie that. The first question on the chat is, can you have a mallet finger and a swan neck deformity injury?
You have a mallet finger and a swan neck deformity injury. Yes, you can. So, and untreated or an improperly treated mallet finger can lead to a swan neck deformity because of the imbalance between the flexors and extensors. So if you miss a mallet finger, what's going to happen is the flexor tendon, let me think about this for a second. So what will happen is, if you look at my finger, you'll get flexion of the distal interphalangeal joint. What will happen next is you'll get volar displacement of the flexor tendons. That's going to essentially pull the finger downwards. Okay, so you can have that swan neck deformity with a mallet.
Thank you. I got a follow-up question. You did mention the return to play, and I think I shared with you a case. It was a high school football player that was trying to return to sports. It was an intra-articular fracture, at least about 50%. That player, even though it was recommended to have surgery, opted not to have surgery done. My question is this: how do you counsel those athletes about if they don't get it fixed? And depending on what surgeon you talk to, I'm not sure how much was stressed that maybe if he had the surgery done, he could potentially return back to football since it's a senior year within a week or two or a few days. Would you have any comments on those?
Yeah, typically for folks who do not want to have a operative treatment on an acute fracture that obviously needs surgery, I'll essentially talk to them about short-term versus long-term. I'll say, we cannot do surgery on this, and you can get back to play in a week or two, but you might have a bad finger for the rest of your life, or if you have any hopes of a college or a career at the next level, you're going to be compromised. Versus, I go through the operative options with them. And like I mentioned on some of these slides, even with operative fixation, we have a lot of really nice percutaneous techniques that can reduce a fracture, stabilize it, and still get them back to play within a couple of weeks. So they're not losing a whole lot, but they get that long-term, they don't burn long-term bridges. So again, I'll talk to them about short-term versus long-term and just really try to level with them. If it's a high school player, I'll also try to, obviously involve the parents.
Thank you. Do you have any other additional questions? Please put it on the chat. I'll ask one more question for Dr. Boachie, and hopefully I can answer or ask any other questions you guys have. For the base fracture that you mentioned, I think you mentioned it wasn't displaced as much, and you mentioned that collateral ligament might be affected. I think it was the last fracture. It's relatively stable. Can that be treated non-operatively?
Yeah, so again, that could be treated non-operatively. I think a lot of it also has to do with the level of activity in the patient, right? I would certainly treat something like that differently in a 17 or 18-year-old athlete than I would in a 70-year-old grandmother. So it's not only about, we treat people, not x-rays. I say that almost every day in clinic. You want to get a sense as to, again, their handedness, their level of activity, if they've got arthritis in their other IP joints, and what else they want to do. That kind of helps to guide the fracture. But I'm not dogmatic. I just give professional advice and make suggestions.
Thank you very much, Dr. Boachie. We appreciate it. Thank you all for attending this lecture today. Remember to stay tuned next week for the next lecture on this series. Thank you.
Thanks, everybody. So good to see you guys, and all the best in your future careers.